it's not an uncommon story. So yes, our cases are going up some, and I think that's just par for the course after being in a nadir for a while. One thing that I follow now, and you might want to start following also, and it is also available on the state dashboard. So if you just Google North Carolina COVID dashboard, you'll get to it. And right on the front page of it now, you'll see numbers reported for sewage monitoring. And what this is we take samples out of sewage from several locations across North Carolina, and then we look for fragments of the COVID virus in the sewage. And here in North Carolina, we did the pilot for that, one of the states that did. And it turns out that the numbers that you find in sewage reflect probably closer now than absolute case numbers. And so you can watch the sewage numbers in a particular community and get an idea whether you're going up or whether you're going down. And it also tends to happen a little bit earlier than the absolute case numbers, and certainly happens faster than hospitalizations, which always lag about 2 to 3 weeks. So if you look for the triad here, we're about plateaued with our sewage numbers. Not really going up, not really going down. Charlotte-Mecklenburg's gone up a little bit over the last couple weeks. And the triangle is going up the fastest. And I'll let you take a look on the North Carolina dashboard, and you can see we're nowhere near the numbers that we were during January with the big Omicron surge. And we're not anywhere near the numbers that we were during the Delta surge. But we're getting kind of close to where we were last October. So if you remember last fall around Halloween time, that's kind of where we're probably really sitting as far as number of cases. Hospitalizations, however, both here and in the Charlotte area, have not increased all that much. And I'd give you more information on the sewage for the mountains up in Wilkes County, but the only mountain town that measures it is in Asheville. So but our hospitalizations really haven't gone up a lot. And so we'll have to kind of keep an eye on that and see. But I can tell you that those people who are in our hospital system and our health system up here right now, all but one are unvaccinated individuals. So that's still the same thing. How are the schools doing? Fairly well. Our case numbers have gone up some in schools, but we don't do the close contact tracing in monitoring in our schools that we were doing, say, last winter. And so it's a little bit hard to know. There are a few private schools that are still doing fairly close contact tracing and monitoring, and those numbers are up somewhat modestly from what they were in the latter part of March. And again, that doesn't really surprise me. The masks are off. People are out and about and socializing a bit more. And so there's more transmission occurring. Our universities, the same thing. Numbers are up some, particularly in the professional schools as they get towards the end of the year. But it's not really been a huge problem or burden for the universities in our area, as opposed to up in Washington, D.C., and in some of the New England schools, where actually some of the schools there have had to go back to mandatory masking in classes, and then a few, even including Howard, have gone back to some virtual classes rather than having in person. I don't see that happening here in our Triad area or here in North Carolina. What are some of the things? Why are we not increasing as much in North Carolina? Well, it's a little warmer down here. People are outside more than they were in the upper mid-Atlantic or New England. And they just still had a snowstorm in New England, so a lot of people are still indoors. Whereas across the whole United States, everyone's taking their masks off. But if you're having your activities more outdoors than indoors, that's still going to keep you safer from getting COVID. And then another thing is to watch is our variants. Everyone's been asking me, what about the BA2 variant? Well, now there's 2 subvariants under BA2, which only have numbers. So that is about 85 to 90% now of the circulating virus across the United States. Probably about 85% of what's circulating here in North Carolina and in our regions are actually the BA2 variant. And the fact that over the last month we haven't had new cases falling out of the sky due to the BA2 variant makes me think that we're not going to have a huge surge from this. I think we would have started to see the early information from that already. When will a next wave or surge be? I think that to say if is probably a little bit too optimistic. I think when is probably the better question. I would not surprise me that if towards the end of the summer we don't see another wave. How high, how big, and how impactful that wave would be is going to depend on whether we have a newer variant that's actually has more of an immune escape than BA2 does. And why would that be at the end of the summer? Well, here in the hot areas, a lot of people go inside where air conditioning is, so there's more indoor chances for transmission. The other is that our immunity is going to start to wane some, both from booster vaccination as well as from the Omicron surge that we have in January. The Omicron surge that we had in January is largely one of the things that's helping protect our population right now, particularly the unvaccinated population. And that, I think, will wane some by August. Again, how high that bump in the end of the summer goes that I'm predicting will depend some on how robust Omicron's immunity is, how long-lasting Omicron's immunity is, and whether we have a new variant or not. I'm more concerned about late fall and wintertime, to tell you the truth. That's when our respiratory virus season usually is. As with previous pandemics of new respiratory viruses, we are going to, I think, see more of a year-long COVID turn into more of a wintertime COVID. And by this fall and winter, certainly Omicron immunity will even have had more of a chance to wane. And I think we're going to see problems. Will we need to bring back masks and other mitigation strategies? Hard to say. If putting masks back on kids going to school means that we don't have huge absentee rates in our school and that kids are able to stay in school more because they have a mask on and aren't getting sick, then yeah, we probably should do that. Well, we need to bring it back on transportation. We'll talk about that in a minute. And so, yeah, I do think, though, that that wintertime is going to be our next major problem. When I say major, I don't think it'll be like January of this past year. And I think that for the most part we'll be able to still go about doing what we want to do. But it's respiratory viral season. That's when the viruses come out. One of the reasons why I wanted to talk about that is because is one of the other more common questions I'm asked right now is about boosters. So the CDC said, if you want, you can get a booster right now. So what do you think, Dr. Ohl? Should I get my number 4 booster or my number 4 shot, my number 2 booster? It's getting a little complicated, isn't it? And so here's what I think about that. I think that if you're considerably older, particularly above the age of 75 or 80, and particularly if you have other underlying medical problems, or if you're younger than that and have more serious underlying medical problems, something you see a doctor for at least every 3 months or so, such as diabetes, heart disease, lung disease, and then I would consider getting a 4th booster now, or a 4th shot, or your 2nd booster now, otherwise, I think for the rest of us, I'd probably wait till fall. And why would I wait till fall? For a few reasons. One is that since I think that our next highest number of cases that we see again in the future is going to be in the late fall or winter, just a long time at the same time as the flu season, I think that it makes sense to get the booster as close as you can to when the problem is going to be the greatest. And so if you get boosted next fall, then your immunity will last through the entire respiratory virus season. And that just makes sense, which is why we give the flu shot in the fall. So the other thing is that there's a lot of vaccine research going on right now. It's not being talked about a lot, but it's plausible that we could have more of a variant-directed vaccine this fall, and one that might be a little bit more robust against the Omicron and its subvariants, in which case it would make sense to get that vaccine, and that's not available yet, but will be potentially available this fall. The other thing is we're learning more about mixing and matching vaccines. So if you got your initial series with Pfizer, and then you got a booster with Pfizer, and you need a second booster, maybe you're going to want to get Moderna. And actually, that's what I did personally. When I got boosted, I switched. And it seems like that provides a little bit longer immunity, and that it protects a little better for symptomatic infection. For serious infection, such as hospitalization or death, it may not make quite as much of a difference, and the reason why is our original vaccines, particularly if boosted at least once, seem to be keeping us out of trouble still. And so that's good news, even with the Omicron and with the Omicron subvariants, such as BA2. So vaccination seems to be hanging in there to protect us. It's not going to all the time protect you from a breakthrough infection, a so-called COVID cold, but a breakthrough in a COVID cold is very unlikely to land you in the hospital. It's very unlikely to give you long COVID, and it's very unlikely to give you a complication that sometimes we see after COVID, such as diabetes. And so vaccination with at least one boost is the way to go. So this week in the news was the fact that a judge overturned the mandate for masking on transportation. And so what do I think about that? Well, first of all, masks work, and they will help protect other people if you are shedding virus, and they will also protect you if other people around you are shedding virus. The second thing is that transportation, where we're all kind of sardines in an airplane or a bus or a train or a subway, is a place where people are closer together, and viral transmission's more likely, and so masking is more important in those situations. But the other thing is that we've entered into an era, and we're going to continue to travel down that road, where you can take personal responsibility for protecting yourself, and whatever anyone else wants to do, that's their issue, and they can do what they want to do. So if you're getting on an airplane and a bunch of people are unmasked, it's on them. And if they don't mind getting sick, then go for it. It's fine. But if you really don't want to get sick, for whatever reason, if you're older, or if you have underlying health problems, or you're immunocompromised, or if you just really don't want to be sick, which you can throw me in that group, because I don't like being sick, and I'm a busy guy, and I like being out there and doing what I want to do. And giving COVID is still disruptive. You're out of commission for 3 to 5 days. And I don't like colds, and I don't like coughing. And so personally, I'm going to continue to mask on an airplane because I don't want to get sick. And there's still enough COVID around that there will be cases that will occur because of unmasking of other individuals on the plane. The one thing I want to say about airplanes is that the airlines have said, well, our air exchanges are so good, our ventilation is so good, it's really not an issue. That is true as long as the engines are running, because the engines are what drive the compressors, which drive the air movement and the HEPA filtration on a plane. So when you're up at 30,000 feet flying between here and Europe, yeah, your risk of getting a virus on the plane, be it COVID or the flu or whatever, is going to be lower. But if the snotty-nosed guy next to you on the plane has COVID, then it doesn't really matter so much about filtration on the plane, because that's the snotty-nosed guy right next to you, and the virus is still going to get on you. And that we've known for ages, actually, that influenza gets transmitted on planes that way, so does TB and other pathogens. It's not just COVID. The other thing about airplanes is if the engine's not running, there's no air filtration on the plane, and then it's possible that the virus can go up and down the plane and side to side. When is the engine not running on the plane? It's when you hear that pilot say, we're going to just pull over here on the tarmac for a little while, waiting for a wheels up time for air traffic control. And then they go to a little airplane parking place down at the Charlotte airport or whatever, and they shut down their engines because they don't want to waste the fuel. And there's no more air circulation. When you're boarding the plane, the engines are not on. They're not on until after the plane is pushed back and that little tug thing is going back to its home. And so during those times, there's no air circulation on the plane other than some very small motors. Now, if the engines aren't running when you're at 30,000 feet, then you have other problems besides air circulation. So that's a little bit about the TSA mandate. To just sum that up, I don't think we need the government to mandate or tell us that we have to wear a mask. I think that most of us can make the decision for ourselves, since an N95 protects you so well that that you can wear one yourself and protect yourself. But cases will go up because not everyone's masking on the plane, and not everyone on that plane will be vaccinated, and they'll transmit it between themselves. Treatment-wise, so because of the sub-variants of Omicron, the BA1 or the BA2 sub-variants, monoclonal antibodies really don't work anymore. And so if you get COVID, don't think that getting a monoclonal antibody is going to bail you out. But not all is hopeless there, because Paxlovid, which is an oral drug, can be used. And it's something you can get from a prescription. Most pharmacies have it now. Doctor can just call it in. And you pick it up, and then you take it for 5 days, twice a day. You do have to watch out, though, because there are certain other medications that if you may be on that create problems with giving that drug. And if that happens to be the case, then you can take another drug, remdesivir, but unfortunately that has to be given by veins, so it has to be set up in an infusion center. Or you could take another drug called molnupiravir, but that potentially has pregnancy problems, so for women of childbearing ages, we are not real hot about giving people molnupiravir unless they have a negative pregnancy test. And so, but anyway, there are treatments. There are a lot more in development right now. In 6 months, we'll even have more out. Hopefully, some of the newer ones won't quite have the drug-drug interactions. But that's one thing to consider. Does everyone need to get treated? No. If you're younger and otherwise healthy, it's probably not necessary for you to get a treatment. But if you have underlying health problems, or you're older, or you're immunocompromised, then yeah, I think treatment would be a good idea. So I don't know if we had any questions come in through the media. Yeah. Shoot, questions from the group here.
Lou asks if you have any updates on the vaccine for kids under 5.
Yeah, oh yeah, Lou. So kids under 5 vaccine. Yeah, I would expect it out soon. Probably in the next few weeks. And it'll be a 3-dose series. And the safety of this has never really been an issue. In fact, the early data shows it's very safe. But we've found out we need to get 3 doses in for that age group to provide a good level of immunity. So that's not too far off. The other thing that's not too far off are booster doses for our 5 to 12-year-olds. And that'll be recommended roughly 4 to 5 months after the full vaccine series, which most of our 5 to 12-year-olds got right around Thanksgiving time last year. And so they'll be eligible for that. And I would recommend that they go ahead and get that, particularly if our case numbers continue to go up. And I think we plan on vaccinating our 8-year-old when that is authorized, which shouldn't be too far from now. And then Moderna's vaccine for kids, I think, was going to be on track. Whether that'll be out in the next few months or whether it'll be out next summer, maybe next summer or this coming summer, I think, for Moderna's vaccine for kids. Moderna has got a combination COVID flu vaccine they're working on and have made some pretty good progress on that, so we'll have to keep an eye on that. There's also some pan-COVID vaccines coming out that work against all of the variants that we've had so far. And they're not messenger RNA vaccines, they're protein adjuvant vaccines, which is a little bit like how we make a lot of the other shots that we get in our life, particularly when we're kids. And that one people are a bit excited about, but we don't have enough data yet to know about how well it's going to work, but keep your fingers crossed. And then Novavax, Novartis' vaccine, which is also a protein adjuvant vaccine. Data has been submitted to the FDA, but I just saw this week that the FDA may not make its decision on that until this coming summer. So there's more vaccines coming out, so which is really good because the more we have, the more choices we have, and the better off we'll all be with this. And so it's something to keep an eye on. Another question.
So Beth says, when do you feel that it would be safe to take a cruise? She's in her 60s, fully vaccinated, and had both boosters. So
Beth, the CDC actually says that they took off their warnings for cruising, so the cruise ships have figured out how to do things a bit better, and so there's not as much transmission on a cruise. And I would say that if you're 60 and you don't have a lot of underlying serious health issues, and you've had 2 shots and a booster, and you want to take a cruise, I think I'd go for it. I'd make sure that the cruise you're looking at requires vaccination for everyone coming on board. And I would bring a few masks with you, so when you're going into that disco to do your dancing, stay masked till you're up on the floor anyway. And I think it's okay. The one thing that I get asked is I've had 2 shots and a booster. I'm otherwise pretty healthy, but I'm traveling abroad. I'm going to France, I'm going to Africa, I'm going wherever. Southeast Asia is open now. I want to go to Thailand. Should I get another booster? Should I get a second booster before I go? Well, for your health, you probably don't need it. Because if you've had 2 shots and a booster and you're otherwise healthy and you get COVID, you're going to get a cold. The problem is you have to test leaving to come back in the United States. And if that test is positive, then you're going to have another 10 days of enjoyment of Paris. And if that works out all right with your schedule, then maybe being stuck in Paris for 10 days is okay. But you're going to be watching a lot of daytime television probably because you'll be in your hotel room. So most people would rather not have that happen. So some people who are traveling, or it would the same thing if you're going on a cruise, have elected to get the second booster, particularly if they're older, and if that booster's been more than 4 to 5 months ago. So it's another area where you might want to think about it just for convenience and to limit disruption in your life. Other questions?
So, got a couple questions about when will hospitals stop requiring masks? Do you want to explain why?
Yeah, so when will hospitals stop requiring masks? Maybe, well, some say maybe never. The thing is why do we require masks in hospitals? One reason is because there's a lot of sick people and immunocompromised people in hospitals. I mean, they're concentrated there. That's why they're hospitals. And so, so masking is a good idea to largely protect these very highly vulnerable people. The second thing is healthcare workers. And healthcare workers are working in and around a lot of other healthcare workers. When you see how we work up in the wards, and if we start giving COVID colds to each other, it hurts an already low workforce. So with staffing issues, there's still a problem in hospitals. So that's another reason. Thirdly, and perhaps the most importantly, is we have to, because OSHA, the regulatory agency, requires it. And if they walk into a hospital for an inspection and find that nobody is masking in the hospital, they could shut you down. But I think the regulations are in there for a good reason. But that's why we have to mask in hospitals. How long and how far is going to depend a little bit on science and regulation, but it may be for a very long time, because any kind of viral transmission in hospitals is probably a bad idea. So, a lot of us who take care of patients are used to wearing masks all the time anyway, but I know for patients it's a little onerous. But hang in there on it, and we appreciate your cooperation. All right, so in 2 weeks, Andrea Fernandez, my great friend and OBGYN specialist, is going to be here, and we're going to talk to her about COVID and pregnancy, COVID vaccination and pregnancy, and try to dispel some of the misinformation about COVID and pregnancy, but also tell people about what the real risks are and how to avoid those. So we'll see you in 2 weeks.